Bueno, damas y caballeros, aquí estamos en Cita con su salud. Quien les habla, José Urdaneta. Muy complacido de que me permitan nuevamente estar con ustedes para discutir importantísimos temas sobre nuestra salud. ¿Qué es más importante en cuanto a la salud que el acceso al sistema de salud? Por eso es que hoy hemos venido aquí a las oficinas de Capital Blue Cross para hablar directamente sobre cómo nos puede afectar o cómo nos puede beneficiar esta nueva reforma de salud que está diseñada para garantizar el acceso de salud a aquellos ciudadanos que no tenían seguro de salud. Con nosotros tenemos al señor Aji Abraham, quien es vicepresidente sobre la reforma de salud para Capital Blue Cross. Y él nos va a estar conversando sobre este importantísimo tema. Aji, it's such a pleasure to be here. Thank you for having us in your place of work and opening the doors so that we can understand a little bit more about the healthcare reform and how it can affect us or benefit us for that matter.
Happy to do it.
Thank you. Now, tell us, first of all, let's try to define what is the healthcare reform and what was it created for?
So it's called healthcare reform. To a certain degree, I'd probably call it health insurance reform. What it's intended to do, the primary purpose of it, I think everyone would agree to, is to allow more people to get access to health insurance coverage. And the reason that health insurance coverage is important here in the United States is because in order to get access to health care, most providers would, well, I shouldn't say most, practically all providers would like you to have health insurance of some form or the other when you come in to see them so that then they can get paid for the services that they're providing.
So certainly we have always said that we have the best health care in the United States. Our problem has always been in terms of the access to that apparatus that can guarantee a quality of life in terms of care. And this is that bridge. This is the bridge for so many. Now, who is it designed for? Of all the people that are out there watching us and listening to us today, who should be paying attention to what's going on and to whom does this not make a difference?
If you have insurance currently through your employer, then chances are that there's not really anything you need to do other than continue to re-enroll with your employer. There are some impacts to you in terms of benefits that might be changing, et cetera. But fundamentally, there's not too much to worry about if you're getting your health insurance coverage through your employer currently. If, however, you're buying individual coverage on your own, or if you're currently uninsured, and especially if you're currently uninsured, you need to know about healthcare reform and its impacts to you and the options it'll make available to you, potentially some of the options it may take away from you, and also how to get coverage in the new world of healthcare reform.
Now, should we think about healthcare reform as free healthcare insurance for anyone? Is this free? Is this a free ride that the government is giving?
I don't know that I would necessarily call it free, although there are some people, depending on income, that may qualify for either free or reduced cost coverage. They generally fall into two buckets, and what I mean by that is if you're a low enough income that you qualify for Medicaid, the federal government is trying to expand Medicaid. It currently hasn't been expanded in Pennsylvania, so that's an important thing to note. The governor of Pennsylvania has proposed a plan to expand it. It hasn't been approved by the federal government yet, so until that happens, Medicaid eligibility hasn't expanded yet. And we can get into later what those income levels are. So one is, if you're eligible for Medicaid, that is generally considered a free program, although I think depending on your income level, there may be some cost sharing involved here or there, depending on the type of Medicaid coverage you have. The second then is if you buy a policy off of the public exchange, which is the federal government's marketplace for health insurance coverage, you can qualify for subsidies, which are tax credits to help you buy that coverage and pay the cost of the coverage. And then also part of the money, the federal government money, is used to reduce the cost share that members have to pay for the services that they're buying. But that only applies, again, depending on income level.
Is this the same level of quality of care of any other insurance that we could get in the market before the healthcare reform? Is this different?
Yeah, that's access? A very difficult question to answer. I would tell you the coverage is certainly comprehensive, and I think we'll get into later the 10 required elements that have to be in the coverage, including things like pediatric dental care. that typically isn't included in a health insurance product, at least before healthcare reform. So there are some expanded levels of care, including things like free preventative services. However, policies that were sold before, there was really no standard or minimum standard for health insurance coverage, although there were some state mandates that states may have enacted to elements that had to be included in health insurance, but there wasn't certainly a national standard, and even state mandates varied from state to state. So that's my long-winded way of saying that the coverage that was available before is not really comparable to the coverage that's available now. In some cases it might be better, in some cases it might be worse, all depending on what your point of view is and what you need out of the coverage. If you're looking for the lowest price but don't really care because you're perfectly healthy and not anticipating any healthcare needs, you probably would have been able to get a lower cost coverage before healthcare reform than you are now, but you wouldn't get the protections that are available now with the coverage that's available on healthcare reform.
So it certainly, it seems that there's some kind of expansion in terms of what is the minimum coverage that we're getting, but of course there's a cost for it.
Yes. As with anything, you go out and you buy a car, the more features you add to the car, the more the cost goes up. Same way with health insurance. The more features or benefits you add to the health insurance coverage, generally the cost goes up.
Bueno, damas y caballeros, hablando con el señor Abraham, quien es vicepresidente para Capital Blue Cross en este asunto de la reforma de salud, él nos está explicando de que la cobertura que se va a obtener bajo la reforma de salud está diseñada para darle acceso a aquellas personas que primero en estos momentos se encuentren sin seguro, que estén comprando seguro ellos mismos de manera privada, pero que aquellas personas que usualmente reciben su seguro a través de su trabajo probablemente no vayan a ser de ninguna forma afectadas, sino simplemente volver a enrolarse en su seguro de salud a través de su empleador. Pero aquellos de ustedes que estén subasegurados o que estén asegurados por ustedes mismos, que estén pagando su seguro privadamente o que no tengan seguro, este seguro es para ustedes. Este seguro no es un seguro gratis, aunque puede llegar a ser gratis o de muy bajo costo para muchos. Es un seguro que hay que pagar de alguna u otra forma por él, pero es muy probable que depende del nivel de ingresos que usted tenga, que pueda tener algunos subsidios o rebajas significativas. Lo que ha hecho esta reforma de salud es garantizar que hay un mínimo de cobertura necesaria que todo seguro tenga que tener, debe tener hasta estos momentos. Y vamos a hablar un poco más adelante sobre esas necesidades básicas. Aji, continuing with the conversation, you said something about that now insurance coverage is going to have some essential needs, some essential coverage that has to be included in your policy. What are those essentials?
So there are 10 categories that were required in the statute itself. They include ambulatory patient services, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse, prescription drugs, rehabilitative and habilitative services, laboratory services, preventative and wellness services, and pediatric, including oral and dental, like I mentioned before.
Okay, which oral and dental, I mean, the United States has a pretty low rate of dental coverage, and it's
well, yeah, this is, so it's kind of interesting that before some of this stuff was never considered part of your traditional health insurance. You usually bought a supplemental dental plan that covered you if you wanted to for dental coverage. Now they're requiring, as part of the statute even, leaving aside the regulations, that the dental coverage, at least for children, has to be included as part of the base plan. As kind of a general rule. So there's stuff that wasn't required before, right, and wasn't ever included before that is now included. There's other stuff, like, for example, hospital services, that typically when you bought a health insurance policy, it included some measure of hospital services coverage. We can talk about whether it was comprehensive or not, but at least that was one of the basic primary elements of health insurance coverage as kind of a, traditionally.
So the preventive side, are we talking mammograms, pap smears, healthy visits for your child to the doctor, and all those things are included on that?
Yeah, the change in terms of preventative services it was primarily that now preventative services have to be provided free of charge for the member. So when you go to see the doctor for your once a year health checkup, that goes with no copay, meaning you don't have to pay anything out of pocket. It's all covered by the insurance policy. Similarly, things like colonoscopies, assuming you're the right age to require colonoscopy, and the plans are supposed to follow the guidelines set by the U.S. Preventative Services Task Force, if I got that name correctly. So there's this national body that sets the guidelines for what good preventative care is, and to the extent that you get that kind of care, then that kind of care should come to you at no out-of-pocket cost for you.
So then we go to the next step, which is qualifying, the levels of subsidy, who is it, how affordable is it, and how do you get to qualify people for the levels of?
Okay, so let's talk about the qualifying for policies through the public marketplace or the federal exchange. If you make between 100 and 400% of federal poverty level, you can go on the public exchange or the federal government's website, which they do have a Spanish language version up currently, although apparently there are some translation errors in the Spanish language website. But if you go to the website, you should be able to get qualified for a policy. And assuming you're between 100% of federal poverty level and 400% of federal poverty level, you should be able to qualify for subsidies and some reduced cost sharing depending on where on that income level you fall. 100% of federal poverty level for a single individual is $11,490. So you would have to be above that. And then below, for like a family of four, 400% of federal poverty level is around $94,200 currently. For an individual, it's $23,550. So if you fit within that range, there's a high likelihood that if you go on the federal government's website, pick out a policy, that you will qualify for subsidies that will either reduce the cost of policy down to zero or at least reduce it substantially.
Substantially. Then we go to the next part. What if someone that is uninsured right now does nothing? Are there consequences?
Yes. If you currently don't have coverage and don't get coverage before March of this year, you will, or actually I guess I should say April 1st of this year, you are potentially subject to a penalty. It starts out at $95 or 1% of your income and then goes up from there yearly.
Yearly. Yeah. So certainly this is a federal mandate. Yeah. That's coming down to us to have insurance one way or the other.
Yes, that's very true, although there are certain people that would be exempt from that penalty. For example, if your income's too low to get to be required to file a tax return, then you wouldn't be subject to the penalty because your income's too low. Basically, the way they're enforcing the penalty is through looking at your tax return.
And seeing whether or not you're paying for health insurance there. How is it affecting then companies like yours, like Capital Blue Cross? What is this doing in terms of how are you preparing for this? What is this opening or closing in terms of the business that you guys do?
So it's a massive shift in how our industry sells policies because now there's much more of an demand on the individual side. Plus, there's a fundamental shift in what the policies look like. As I mentioned, there are benefits now that we never had to cover before that are now required. We can argue about whether or not they're good or not, whether a man should have to buy maternity coverage, for example. But it's now the law, so we've had to adjust our policies to comply. We've spent a lot of time and outreach trying to set up our own website where people can go in and buy policies directly from us, including potentially with some of the subsidies available to them. So it's required a kind of a fundamental shift in our business to be compliant with the law, first and foremost, and then second, to get people aware of the opportunities that they have to get coverage so that they can take advantage of the new coverage options that may be available to them.
Now, at the same time, is this in any way opening new markets?
Certainly, it's always exciting if you've got a new pool of people that who traditionally didn't buy or couldn't buy your coverage that all of a sudden are now able to do so. So, to the extent that the subsidies encourage the currently uninsured to buy our policies, that's a great thing. So it makes it more affordable for them, which means they get coverage and we get another customer. We'll have to see what the numbers look like at the end of the year in terms of how many of people who buy through the exchange were uninsured or just previously insured through a different mechanism and then bought through the exchange. The numbers still aren't clear on that yet.
Bueno, damas y caballeros, continuamos nuestra conversación con el señor R.G. Abraham de Capital Blue Cross. Él es el vicepresidente para la reforma de salud en esta compañía de seguros. Y él nos está hablando de cómo ha cambiado la forma de ellos hacer, o cómo va a cambiar la forma de ellos hacer su negocio debido a que hay estos requerimientos mínimos de cobertura que tiene ahora esta reforma de salud, que cubren el cuidado preventivo, el acceso a la emergencia, la sala de emergencia, los cuidados de pediatría, la cobertura para la salud dental, para el odontólogo y otra serie de requerimientos mínimos que obviamente han cambiado y que no estaban incluidos antes en la reforma de salud. Esto ha abierto, de acuerdo con el señor Abraham, una nueva, vamos a llamarlo, pecera de clientes que antes no tenían acceso a comprar seguro de salud. Y él dice que está por verse qué va a pasar a final de año, de cómo va a ser ese cambio, si va a ser positivo o no para empresas como Capital Blue Cross. Y definitivamente es algo que debemos ver. Nos habló también de quiénes califican, califican para los subsidios, para quiénes puede llegar a ser esto un seguro de salud gratuito. Y él nos ha hablado de que las personas que están entre el 100 y el 400% de el nivel de pobreza federal pueden llegar a tener más cerca, mientras más cerca esté del 100%, entonces más puede llegar a ser cero el costo del cuidado de salud. Mientras más cerca esté del 400%, obviamente más costoso puede ser. Para una persona individual, el 100% es de $11,490 en estos momentos y el 400% a $45,960. Estas son las personas que van a calificar para el mayor subsidio. Una familia de 4 personas, por ejemplo, va de $23,550 a $94,200. Vamos a continuar para entender un poco más sobre esta reforma de salud. Aji, what about the people that are below the 100% poverty line?
So here the federal government tried to expand for them Medicaid, which is also known as medical assistance. Currently, I think the single adult has a hard time qualifying for Medicaid in Pennsylvania, and even if you have a child, I think it only goes up to 35%. It varies depending on income and as well as family status. So my point being, it's a fairly low level to currently qualify for Medicaid.
But you had said that in Pennsylvania, it has not been expanded yet.
Right. So what the healthcare reform law did was it gave states the opportunity to expand that up to 100% of federal poverty level. So then everyone would have an opportunity for coverage. You'd either qualify for Medicaid if you're below 100%, or if you're above 100%, you'd qualify for subsidies on an exchange-based product. Pennsylvania has not yet accomplished that expansion for the below 100% of federal poverty level. So Medicaid is not an option here currently if you're above 35 and below 100% of federal poverty level. The governor's proposed a plan to the federal government. The federal government has yet to approve it. Theoretically, if it was approved, you may see that coverage go into effect, or that expansion go into effect, as soon as January 1st of next year. But for the moment, there's kind of a donut hole or a gap where people won't have access to coverage. And not that I'm encouraging anyone to move, so don't take this the wrong way, but there are states around us that have expanded, for example, Maryland or New Jersey, that do have the Medicaid expansion. So if you live there, you might qualify for the coverage.
What happens if I have insurance right now, but after April 1st, either I changed my job or I decided to open my own business, divorce, death in the family, or whatever it may be, that I lose my coverage because of that. How do I get enrolled?
Okay, so there's a couple rules that come into play here. One is there's an open enrollment period during which anybody can buy coverage. That's what we're currently in. It started in October and it runs through the end of March. The requirement under the law is that you have coverage for this year, which would be 2014. I think it's, off the top of my head, 90 days that you're allowed not to have coverage for and not be subject to the penalty. which is why everyone says you need to have coverage by the end of March in order to not be subject to the penalty this year. So as long as you get coverage by the end of March, you should be free from the penalty or not subject to the penalty. On top of that, if you have certain life event changes, so if you have a child, if you lose a job or you get a job, you're allowed to change coverage, and even if you're not in the open enrollment period. So if I was in June and I lost my job, then I could go to the exchange and sign up for coverage because that was assuming I had coverage through my job. There was a life event that caused me not to have coverage, so now I have the ability to go get it off of the exchange.
So in other ways, you would have to show justification why you're doing it after the March deadline.
Yes, and then there will be another open enrollment period that I think they're talking about starting that in November of this year that would be for 2015 coverage.
Okay. Bueno, damas y caballeros, continuando con esta conversación sobre la reforma de salud, el señor Abraham nos ha expandido un poco más nuestro conocimiento sobre esta ley y lo principal es que hay una meta final para esta primera inscripción que es el 31 de marzo. Pero eso no quiere decir que si después del 31 de marzo hay cambios en nuestras vidas, que nosotros no podamos inscribirnos. Pero obviamente vamos a tener que justificar el por qué lo estamos haciendo después del 31 de marzo. ¿Por qué es el 31 de marzo? Porque el máximo de tiempo en un año que uno puede estar sin seguro de salud son 90 días. Y el 31 de marzo son los primeros aproximadamente 90 días del año. Entonces, por eso es que después de eso tendríamos que justificar a qué se debe el cambio. Si es cambio de trabajo, pérdida de empleo, nacimiento de un bebé o cualquier otra cosa que haga que tengamos que comprar seguro de salud después del 31 de marzo. De resto, lo importante es que para aquellas personas que están por debajo del nivel de pobreza del 100%, esas personas van a poder todavía tener acceso al seguro de salud si en el estado donde viven hay una expansión de lo que se llama la cobertura del Medicaid, que desafortunadamente aquí en el estado de Pensilvania eso no ha sucedido todavía. El gobernador ha hecho una propuesta de cómo expanderlo, pero todavía el gobierno federal tiene que aprobar esa propuesta del gobernador de Pensilvania para que pueda ser aprobado. Mientras tanto, en estos momentos hay lo que se llama un agujero en cobertura para las personas que están por debajo del 100%, por lo menos en Pensilvania. El señor Abraham nos ha dicho de que por lo menos en Maryland, en New Jersey, en otros estados, ya tienen esa expansión del Medicaid y si hay cobertura, si las personas están por debajo de ese 100% de nivel de pobreza del gobierno federal. Esto no se ha terminado, vamos a tener otro programa para hablar aún más porque esta reforma de salud es tan amplia y complicada que vamos a tener otra cita con su salud para hablar más sobre ello. Muchísimas gracias, hasta la próxima.